All right. Hello, everyone. Good afternoon or good morning, depending on where you are at. We're going to give folks just a few seconds to join before we get started. All right. Well, hello, everyone. Thank you so much for joining us this afternoon or this morning. Welcome to our training, Integrating the Measurement of the Social Determinants of Mental Health into Clinical Practice. My name is Emily Moore. I am the project manager for the Southeast Mental Health Technology Transfer Center, and I will be facilitating today's training. And we will just go ahead and get started without any ado whatsoever. Really quick word about our center before we get started. Please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also please note that our center and the larger MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities. I encourage all of you to do the same while you are typing in the chat or in the Q&A feature throughout today's presentation. And this is me. I'll be presenting today's training. A little bit about me. I am a public health professional by training, and I have expertise in how societal and cultural factors affect health outcomes, particularly mental health outcomes. And I have been working as the project manager of the Southeast MHTTC for 6 years since our founding in 2018. And really, the reason that I'm the one to give the training today is because integrating the measurement of social determinants into mental health practice really is looking at mental health care from a public health perspective or a public health viewpoint. So I'd ask you all to put on your public health goggles for today's training. This is what we're going to be going over during today's training. We're going to be describing how the social determinants of mental health impact patients' access to and engagement in care. We'll be talking about the benefits and challenges of implementing a tool to measure for the social determinants. We're going to describe one tool in particular, the CMS Health-Related Social Needs Tool, and how it and other screening tools like it can be utilized in clinical practice. And then at the very end, we're going to talk about an integration plan to implement these measurement practices into your everyday work, or how to advocate for the measurement of these determinants if you happen to be in a frontline role and not in an administrative or directorial role. These are the parts of the training. First, we're going to go over the social determinants of mental health, so we have a good public health view of what they are. Then we're going to talk about assessment. And finally, in step 3, we will dive right into integration. So step 1, let's just go over the social determinants of mental health. And before we do that, I really would like to know more about you all. So if you feel so inclined, please type into the chat your current role in the behavioral health or the mental health field and what sort of setting you currently are working in, whether it's a community mental health center, state mental health hospital, something adjacent. Please go ahead, type in your current role and what your work setting is into the chat. I'd love to know who I'm talking to today. Family services, community mental health center, awesome. Community mental health center, statewide coordinator, social worker, medical case manager, social worker, brain injury advocate. Amazing. Oh, we have such a wide array of disciplines and professions, recovery coaching. Excellent. We have some diverse disciplines. That's great to see. So let's go ahead and dive right in. What are the social determinants of mental health? Well, I think it's important to note that we don't obviously arrive at a health outcome, be it good or bad, in a bubble of our own making. The things that surround us and the things that happen to us have a role in determining the quality or the lack thereof of our health and our mental health. So, in the same way that the World Health Organization defines health as more than just the absence of disease, mental health is also more than just the absence of a mental health disorder. Um, these societal factors really play into how our mental health is going to be shaped, whether they're environmental, political, cultural, financial, they all work independently and in tandem with each other to determine our health outcomes. And a determinant can be something very tangible, like the built environment, whether your city is walkable or not, or it can be something very abstract and hard to grasp, like culture. Determinants can be something such as the experience of discrimination, or even something from one's past, something that is not currently happening but happened in the past, such as an ACE or an adverse childhood event, or whether or not you had access to education or support as a child. Oops, sorry guys. And the social determinants of mental health are much the same as the determinants that lead to physical health outcomes. All of these factors have the potential to either be protective or be risky, as in they increase a person's risk of developing or worsening a mental health disorder or illness. Culture plays an incredibly unique role in determining mental health outcomes because the way that we view and talk about and even somatize mental issues is very much determined by our culture. An example of this might be how English speakers will say that they feel blue, right, when they are feeling depressed, whereas a person who speaks another language from another culture would express depressive symptoms very differently using very different vocabulary. As we'll see, culture also plays a very large role in whether or not a person will access or has access to treatment. So ultimately, there are two contextual factors that drive risk for mental health issues. Those two contextual factors or determinants are public policies and social norms. So for public policy, we have things like the Mental Health Parity Act that requires that mental health conditions be covered by insurance, right? We have the Americans with Disabilities Act that prohibits discrimination because of a mental health condition. Things like having a robust mental health workforce in your state, mental health clinicians who are able to bill for their time. That means that there will be enough providers who are paid well enough to actually treat the population. Having a healthy crisis infrastructure can address mental health emergencies without overburdening other mental or other emergency services. And then, of course, the expansion or lack thereof of Medicaid and Medicare is going to affect whether or not those who live in poverty or the elderly are able to receive treatment. As far as social norms, in our society, as I'm sure you're well aware, there are certain people for whom it is okay socially to have mental health issues. In the research, it is found that if you happen to look like me, if you're white, female, upper middle class, etc., mental illness tends to be more socially accepted. However, if you are male, if you are Black or brown, if you're from a lower socioeconomic class, then our society is not as accepting of mental illness in that population. And so if you meet that criteria, you are at a higher risk for experiencing adverse mental health outcomes. At the same time, there is stigma still surrounding mental illness. Even though it's more acceptable in certain populations, there's still stigma surrounding mental illness. People who are mentally ill are seen as violent or undesirable, unemployable, etc. There are also cultural and religious beliefs that increase risk of adverse outcomes. People say things like, oh, you just need to pray harder, or you're under spiritual attack. There are beliefs like these, similar beliefs, that might discourage treatment and actually increase risk. And then, of course, there's social roles that might also dissuade people from getting the treatment that they need. For example, people who are new parents, people who are religious leaders, men in general are usually dissuaded from seeking out mental health treatment and admitting that they have mental health issues that they would like to solve. And this leads to that social pressure, that social oughtness. You know, you ought to man up, get over it, try harder. So those are the two contextual factors that really are driving risk as far as how determinants drive up risk for mental health issues. Another quick chat poll, out of all of those determinants that I've listed so far, for you personally, which have the greatest impact on the populations with which you work? What have you noticed in your work that really seems to be a large driver of mental health outcomes and really plays a large role as a determinant? If you feel so inclined, please share some of those determinants that you've noticed in your work in the chat. I can, yeah. I'll go all the way back up. So these are just examples, right? Stigma. Mm-hmm. For those unfamiliar, that ACEs is just adverse childhood events, trauma that might happen in childhood. All of them, yeah, yeah. All of them at once working together. Access, SES. Mm-hmm. Yeah. And SES determines so much. Socioeconomic status is such a determinant for whether or not people develop a mental health issue and whether or not they're able to seek any sort of treatment for that issue. ACEs, education, environment, yes. Yeah. So all of them, definitely. Thanks for sharing, everybody. So how do these social determinants of health affect engagement with care? Well, these are some examples of how public policy might impact your client's engagement or their ability to engage with your care. So ability to find transportation. Obviously, if you don't have a car and you live in an area that is built around the car, you have to rely on friends, family, or public transportation, right? If you live in an area with really poor or unreliable public transportation, you know already you are much less likely to make it to your appointments. Without a car, which is easier, getting to an appointment in a city that has a built government maintained infrastructure, like say a Boston, or getting to your mental health appointment in rural Kentucky if you don't have a car. You know, that public policy, that infrastructure, it's going to affect your ability to engage with care. In some states, we have folks that have expanded their Medicaid programs to cover all people with household incomes below a certain level, right? And then in other states, they have chosen not to, right? So let's say that you live in one of those states that haven't, and you're living with a mental disorder that makes it difficult to maintain a well enough paying job to provide coverage for your mental health treatment. How do you afford treatment? How will you afford insurance? How will you afford medication? That public policy of deciding not to expand certain services has affected your ability to engage. And then, of course, you may have trouble accessing medications due to legislation or the current economic market. And even if you can get your meds, due to the education system in which you were raised, you might not have the health literacy necessary to comply with your medication's directions or even know how to navigate the complicated, convoluted system to know how to pay for or get enough medication over time. So these are the way that those public policies affect engagement. But how do social norms affect engagement? Well, cultural and religious beliefs. So I live in the Deep South, in what's known as the Bible Belt. And for sometimes better, sometimes worse, our culture affects how people view mental health challenges and whether or not they will seek out and engage with care. The same can be said for other belief systems, other religions that view mental health disorders as spiritual warfare, or belief systems that simply teach that a person just needs to do better or try harder. If that's your belief system, you are going to be less likely to try and engage with care because you don't think that it's the right thing to do. A person might also have trouble finding a provider that can connect with them culturally. I said before that culture and language often determine how we express our mental health challenges. If you are a brown Arabic speaking man living in rural Alabama and you happen to be struggling with a psychiatric disorder, how likely are you going to find a clinician who is fully prepared to treat you within the context of your understanding and your expression of your mental health? You can turn that around. Like, imagine if you are a white American Christian living in a predominantly Muslim culture. How comfortable are you going to be in seeking a therapist when no one around you looks like you or understands mental health challenges through your lens? And then, of course, we know um, that stigma against serious mental illness, it definitely persists. We have done so much better in the last decade in destigmatizing mental health challenges such as depression and anxiety. Social media has played a huge role in that, right? Making it okay to talk about depression, okay to talk about anxiety. It is very easy now to like, a celebrity's post on social media about their struggle with depression. People call them brave, all of that stuff. And yet, the public still shies away from helping the person experiencing homelessness, people experiencing psychosis, things that are less glitzy and glamorous, things that to us might seem objectively scary. There's still judgment and lack of knowledge surrounding things like postpartum depression. And those types of folks are still viewed with suspicion and stigma. So there's still a lot of work to do, even though we've come a long way in the last decade or so. There's still a lot of work to do to reduce stigma as a social norm that affects engagement with mental health care. So some of you, if not all of you, are probably thinking, yes, I know this. This is all very frustrating. And it's difficult for providers to begin thinking about how they can mitigate determinants that increase risk because providers are usually asked or expected to treat patients and symptoms. You're not expected to change the world outside of the clinic, nor should you be expected to change the whole world outside the clinic. But because the social determinants of mental health are driving the things that you see inside the clinic, paying attention to these social determinants and trying to at least address the ones that affect your population, it can be and should probably be a part of treatment. And because it's so challenging, as we all know, to change policy and to shift social norms, those two contextual factors, we might think that providers like you have very little power to address the social determinants of mental health. But when we look at it closely, you're not trying to do a cataclysmic world change, right? You're trying to help your clients change how they're able to live, work, and play within your sphere of influence and within their world. And you really can do this by adopting a public health view of mental health issues and by identifying and addressing the social determinants of mental health, much in the same way that you identify and address symptoms. And so, how do providers usually identify and address symptoms? They do it through screening, tracking, referral, and follow up. So, to do that, we need a screener, we need a way to store data, we need strong partnerships with outside programs, and we need measurement-based, systematic follow-up over time. Now, before we go on to the second step and I start talking about those 4 things that I mentioned, the tracking, the referral, the follow-up, all of that, I think that it's very important to touch on structural competency and a trauma-informed approach. These are 2 things that agencies will want to implement if they want to do this type of measuring for the social determinants of mental health and screening and tracking for these social determinants. So to start out, what is structural competency? It's a framework of thinking. It's something that providers need to have in mind under their consideration when they are caring for people from traditionally marginalized, historically oppressed, or othered groups. All of those determinants that I mentioned at the beginning of this training, that long list that I went back to on that slide, all of those determinants disproportionately impact people from those groups, and usually not for the better, right? So having an idea of the injustices, the struggles, the unique challenges, and the inequalities that are statistically more likely to affect Black, Indigenous, people of color, people from the LGBTQ plus community, etc., keeping those things in mind is going to offer providers clarity regarding that patient's experience of their mental health issues. It's understanding what we talked about at the very start, that we don't arrive at mental health outcomes in a little isolated bubble of our own making. Oftentimes, the symptoms that folks are experiencing are exacerbated or sometimes even determinant by the inequality and the injustice that they faced, by the unfair policies that have been a part of their lives. So structural competency is a framework to have in mind when approaching the care of these traditionally marginalized groups. The other thing to have in mind is a trauma-informed approach. Oftentimes, the public institutions and the service systems that are intended to provide services and supports for individuals, those systems are often themselves trauma-inducing, right? In behavioral health, the history of coercive practices, seclusion, restraints in the behavioral health system, the abrupt removal of a child from a family in the child welfare system, the use of invasive procedures in the medical system, harsh disciplinary practices in educational systems, the intimidating practices of the criminal justice system, all of that can be incredibly re-traumatizing for individuals who enter these systems and enter these services, but who have significant histories of trauma. So a trauma-informed approach is what is needed. The guiding principles of a trauma-informed approach that organizations would need to have in place would be safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and personal choice, cultural and historical and gender issues in mind. Adopting a trauma-informed approach in your organization requires work, a lot of work. It requires constant attention, caring awareness, sensitivity. It possibly requires a cultural shift at the organizational level. And all of this is done through ongoing internal organizational assessment, quality improvement, as well as engaging with community members, community stakeholders. They'll help to embed this approach that can be augmented within your organization and improved within your organization to make sure that you have safety in mind, you have trauma in mind, and you're not re-traumatizing clients. So when screening for the social determinants of mental health, screening for trauma should be a part of that screening process because trauma itself can be a social determinant, right? An example from a recent webinar that our center had, it was actually concerning faith and spirituality and mental health outcomes. As we discussed before, religious belief can be a major determinant of mental health outcomes, right? A certain provider was talking about screening an individual and asking, are you religious? And the person saying no. And it might seem easy, especially from a cultural perspective, to ask, oh, well, why not? However, that very question might be re-traumatizing and might cause some people to become very closed off and very defensive. So instead, opening it up in a trauma-informed approach would look like reframing the question and asking the person if they would like to give more information with an open question like, was, there ever a time in your life when you were religious? So that the person can say yes or no. And if they feel like giving more information, they can. But if giving more information would be re-traumatizing, the ball is in their court and you have gotten the information that you needed for your screener without potentially re-traumatizing an individual. So, all right, that is the end of part one. We've been going for just a little under 30 minutes. I am going to take a very quick 4-minute break. It is 12:26 where I am. If you need to get up, stretch your legs, use the restroom real quick, get some water, I am going to come back and restart right at 12:30 Eastern on the dot. So I will be right back. If you also want to take a very quick break, feel free to do so. We'll get started in 3 minutes now. Um, I was about to say, we can start the recording again. Let's go ahead and dive right into step two, or part two of the training, which is assessment and how we're going to go about, or one of the ways we can go about assessing for these various determinants that we've talked about. So first of all, why measure for the social determinants of health in your everyday practice? Well, we kind of already answered this question at the end of the last module. Screening for these determinants will allow providers to adopt a public health perspective or a public mental health perspective and understand the risks and the causal factors in their patients' lives, and will help providers to appropriately adjust treatment based on what's going on outside of the clinic, right? People who are living with mental illness, mental health disorders, they can receive great care from their providers, right? But if their societal circumstances don't improve, then it's almost like doctoring a war wound in clinic and then sending your client right back out into the battlefield, right? We want to help patients change or even leave the battlefield. So how can we measure for the social determinants of mental health in everyday practice? Well, we break it down into what can be done at two levels, the individual provider level and the organizational level. So providers can do things, agencies or organizations can do two things. Providers can detect the societal factors that influence the health of their patients or clients, and they can consider those factors systematically over time while planning and providing treatment. Agencies or organizations can provide a way to store and use that information or that data over time so they can tailor to the mental health needs of their communities. And agencies and organizations can leverage connections to help clients and patients address social factors influencing their health outside of the clinic. So time for another quick chat poll. If you know this, does your practice or where you work use some sort of intake or interview question that already assess for social determinants? And if so, do you know what is done with that information? Do you know how that data is utilized? So if you wouldn't mind in the chat, does your practice already use some sort of determinant intake? And do you know what is done with that information? No, that's a lot of folks. No. For assessment of services, intake doesn't include it. Yeah. Okay. It's incorporated into the treatment plan. Amazing, amazing. That's so awesome to hear. In the process of trying to get that up and running, awesome. I hope this is helpful in thinking about that process. Anybody else? Okay, well, even if your practice or your organization doesn't have an intake or a screener or a way to assess for social determinants, or if your organization is in the process, maybe talking about the way that some places, one place in particular that we're going to look at has done it, will help give you some ideas. So we're going to look at one example of a screener tool that is open and available. Sorry, that was my dog shaking. An example of a tool that is open and available for any provider, any organization to use. And that is the CMS Accountable Health Communities Health-Related Social Needs Screening Tool. We're just going to call it the HRSN. That's a lot. There are other tools out there in your clinic or facility, like some of you said in the chat. Your facility might have already have its own screening tool, might have already designed its own screening tool. We chose to highlight this particular tool because there are already outcomes and case studies available that you can learn from, so that you can review the full screener yourself. So Shreya is actually going to drop it in the chat as, I think, a PDF, right, Sush? Yeah. Yes, as a PDF. You're welcome to download it and take a look at it. It's pretty long. It's become longer in the last couple of years, but you're welcome to look at it while I talk. So the CMS HRSN, the Accountable Health Communities model was a program that addressed a critical gap in between clinical care, and it wasn't behavioral health, it was primary care, and community services in the current healthcare delivery system. It was trying to test whether systematically identifying and addressing the social needs of Medicare and Medicaid beneficiaries through screening and referral and community navigation services would actually impact healthcare cost and impact the use of healthcare services. There were 28 participant organizations across the country that participated in this study. This study, this model, it was based on the emerging evidence that addressing what we've talked about already, addressing social determinants of health through actually linking folks with services in the community can improve health outcomes and reduce costs. Unmet social needs such as food insecurity, inadequate or unstable housing, it increases developing chronic conditions, the risk of developing chronic conditions. It can reduce an individual's ability to manage those conditions, increase healthcare costs, lead to avoidable healthcare utilization, all of that. These were not, as I said, psychiatric or mental health facilities that participated in this model, as we'll see, but from what we've already talked about, we know that all of that other stuff that affects physical health, affects mental health, food insecurity, unstable housing, all of that. The tool had originally 5 core domains, and it had 10 questions that covered these 5 domains. Now the tool has been expanded to include 30 questions, which cover these 5 domains that you see on your screen, as well as 8 subdomains. And these 8 subdomains cover financial strain, employment, family and community support, education access, physical activity, substance use, mental health status, and disability. So how can a screening tool like the HRSN, the health-related social needs tool, be used in a practice like yours? Well, it would mean altering clinic flow to make the HRSN or a similar tool part of clinical intake. Providers and clinic offices would need to adopt a shared uniform system to store the data that was collected by that screener. And then providers and partners, which we'll talk about in a minute, would share responsibility for patient referrals and outcomes. And how would that be done? How would you collect and decide on treatment plans over time? Well, this would be done using something called measurement-based care. I said a little while ago that um, clinics would need, clinic offices would adopt a shared, uniform way to stare and use data with a goal in mind. And that's where measurement-based care comes in. So what is measurement-based care? Measurement-based care, it describes the evidence-based practice of using systematic and routine assessment intake of the patient's perspective through patient-reported progress and outcomes, symptoms, functioning, social determinants, throughout the course of mental and behavioral care to inform treatment decisions and hopefully to engage patients in their own treatment. Measurement-based care really does promote data-informed and patient-centered care. So how is measurement-based care carried out? Well, through these steps, collecting, that's using the screener. Traditionally, this has been done focusing on symptoms. In what we're talking about today, we're proposing that you do this focused on social determinants, but routinely collecting patient-reported outcomes instead of focusing on symptoms, focusing on those determinants. Then adjusting based on what is learned from that screening, continuously adjusting systematically over time based on the outcomes that patients report. Then incorporating all of that data into a registry, such as a spreadsheet or an electronic health record. Then sharing timely feedback with patients and the treatment team, making sure everyone is in the loop, and then acting, making these updates and changes over time and acting on these data in the context of the provider's judgment and the patient's experience. So how would we apply measurement-based care to the social determinants of mental health? Well, we would collect, same thing that we said in the last slide, make adjustments, enter data, update the clients and the treatment team, and troubleshoot with the client with goal setting and connecting the clients with resources. This means that the clinical decision-making occurs in partnership with the patient, informed by the best research evidence. It's taking into consideration the available options and the patient's individual circumstances and preferences. Treatment planning in this manner is ongoing. It's self-updating. It's adjusting care as needed through regular monitoring and patient progress. And the key element of measurement-based care includes measuring progress, using information from screeners and data collection to adjust care, and sharing that information with patients and treatment team to make the best joint decision. So, okay, that was all theoretical and how, how we would do that. Let's go ahead and dive into the actual meat and potatoes of how you would really integrate this into practice. And the first thing that we're going to do is we're going to share something else in the chat. This is a case study called the Building Bridges case study. Again, we're looking at this case study as an example. This is not the only way to use measurement-based care to assess for social determinants. And this is not even a psychiatric facility or a behavioral or mental health agency. This, I think, is a United Way, but it really does show how some folks have already integrated a screener, measurement-based care, referrals, and linkages into practice. So just to go over really quickly, so Shreya put it in the chat, but it's pretty long. I think it's over 4 pages. We're not going to read every single page, but just to tell you what these folks did so that we can better describe what we're proposing that agencies can do. The United Way of Greater Cleveland really worked together in the Accountable Healthy Communities model to bring together clinical and community services. So they created an advisory board to identify the need for a referral system. They brought together local public health departments, health systems, regional organizations. They conducted a community-wide needs assessment to better understand barriers keeping people from accessing care. The health systems agreed together after they did this needs assessment that some barriers were much better addressed in community settings rather than in clinical settings. And so each health system invested in a screening and referral system that could connect patients or clients to resources in the community that were appropriate for their needs. So before all of that happens, before you know, say, oh, we need to get together an advisory board, we need to implement a screening for the social determinants of mental health, we need to start doing measurement-based care, we need a referral system, we need all these things. Before that happens, obviously, you have to advocate for these changes to be made. And I know from looking at your responses in the chat that some folks are frontline, boots on the ground providers and might want to enact some of these changes, but aren't sure how to approach leadership and have these crucial conversations. So how can we increase leadership buy-in to measure for the social determinants? Because unless we have leadership buy-in, all the other stuff that we're about to talk about, it's not going to happen. So first and foremost, leadership needs to hear that tracking the outcomes of patients demonstrates the value of mental health care. They need to know that research shows that behavioral health providers usually only detect about 19% of patients who are worsening with judgment and just standard practice without referral, without measurement-based care. Detection is even lower for those whose symptoms are not improving as expected. So providers can't know that people aren't improving if they aren't measuring over time, right? What gets measured gets managed. Measuring allows clinicians to track when patients are let go from care. Frequent measurement also alerts clinicians to when treatment should be changed. And one-time screening and assessing determinants and outcomes very infrequently can provide context for what is actually happening outside of the clinic. And that means that the provider usually is just treating symptoms and not treating the whole person. So this is the stuff that leadership needs to know, how advantageous it can be. Another thing that can also help leadership understand the need for measuring for the social determinants, for referring folks to linked up partnerships outside of the clinic, is conducting a needs assessment. So this is a very public healthy thing to conduct a needs assessment or a gap analysis, but it's just a process used by agencies and facilities to identify strengths and gaps to inform improvement and to advance future plans. So before anything else happens, a needs assessment might be necessary. This is done by convening a team, reviewing what data you already know about your clients and the communities in which they're living, collecting more data if you need it, finding a way to aggregate and analyzing that data. That might mean bringing someone outside in to do that big data analysis for you, summarizing and sharing the results with leadership so they know, hey, this is what's going on in and outside of the clinic, and then determining how best to leverage your strengths and fill those gaps. According to SAMHSA, these are the key steps. In a mental health needs assessment, you're going to define your goals. Your goal might be just discover the needs of our clients, discover the needs of our community. Your goal could be discover the needs of our clients and community with the goal of enacting, measuring, new screening for the social determinants of mental health. You want to articulate the purpose of the assessment, not only to leadership, but to the folks who are enacting the assessment. You'll identify your target population for the assessment. That could be just the folks that utilize your facility or your agency, or it could be a broader community mental health needs assessment. You'll determine how data is going to be collected and used. Are you going to use a screener? Are you going to do door-to-door? Are you going to do an app? Are you going to do an email survey? Are you going to circulate something at intake when folks come in? You'll determine the timeline for the process, treat it like a project. It has a start and an end. And then you will determine the strategic use of your findings. What do you want to do with what you're going to find out? And then after that is done, now that you know how to approach leadership and how to conduct a mental health needs assessment, should you need to do one, we can start talking about integration step by step. So first and foremost, you would decide on a measurement tool. This could be the HRSN or another method. Like we said, the HRSN is just an example of a screener that you could use, but you would decide on a measurement tool. It usually is very helpful to identify a clinic champion. If you're the person that's really gung-ho about measuring for the social determinants, I'll go ahead and spoiler alert, the champion's probably going to be you. You would identify your community partners. We'll talk more about this in just a second. You would assemble a project advisory board made up of your leadership, your frontline providers, your community members, your partners, your community partners, and your clients or patients. Next, if needed, all of you together, all those groups I just named, would conduct that mental health needs assessment. This might involve partnering with a consulting team if a gaps analysis or a needs assessment is something that your clinic has never done before. Then, after you learn more about the specific social determinants and mental health needs that affect your community, your clients, your patients, that is when you would create community resource referral systems, outside entities, outside services to which you can refer clients and patients to if you find through your screening that those needs are best met outside of your clinic. You would then form an internal learning collaborative to make sure that all of your leadership, all of your frontline staff, all of your providers are trained on measurement-based care, trained on how to take in the screener, make sure that they're entering in what they find from the screener, they're checking it over time, they're making referrals, they know how to contact different community partners, they know who to contact, all of that. If possible, you would do some quality improvement, some CPI or CQI, and improve upon those methods through expert consultation and maybe even leveraging incentives for staff if needed. And then you can do the thing. You can use your social determinants of mental health screener tool to assess patient needs, and you can find out more about what they need. You can connect those patients and clients to services that can help address their needs, and you can track their progress systematically over time using methods such as measurement-based care and adjusting your interventions based on those results. And then you repeat. So what are some of the evidence-based programs and practices and services that you might think you need to connect patients and clients with? So we talked about assembling your advisory board. We talked about putting together your referral system, all of that. Who do you invite to the table? Who do you refer patients to, right? And these are some evidence-based programs and services that may or may not exist in your community that would be really helpful to connect clients to over time after you've assessed for their social determinants. You can do treatment modalities, you can assess for and treat symptoms, you can do all of these things, but these are the services that you can't always, depending on your place of work, can't always address in-house, in clinic, right? So things like supported employment, making sure that people have well enough paying employment, supported housing, making sure that housing is stable, and that people are not experiencing homelessness, food banks dealing with food insecurity, making sure that people and their children or their dependents have enough to eat, shelters, if a person is unhoused or if a person or a child is experiencing some sort of domestic violence situation and needs to be moved to some sort of shelter. Crisis services, making sure that you understand crisis services, how crisis services have changed recently, especially in the past year and a half in the world of 988, and making sure that your clients and patients and the community members understand crisis services and how they have changed. Peer services and networks, consumer networks that can hook people up with peers and peer networks that have lived experience, and peer services that are appropriate for their particular age group or issue, whether it's, peer youth services, family services, peer addiction services, anything like that. Also, in the same line, addiction and substance use disorder services, making sure that if you find through your screening process and your tracking over time that any client has a co-occurring disorder, that you are able to refer them out to the appropriate services if you're not able to meet those needs in-house. Faith-based organizations. Faith-based organizations play a huge role in assisting, supporting, and bolstering mental health services, understanding which faith-based organizations are available in your community, understanding the overall faith or religious or spiritual culture of your community so that you can make the appropriate referrals to folks should they wish some sort of faith or spiritual based organization to help bolster what they're doing. Transportation services. All of these things are great, but they're only great if folks can get to them. So understanding how there are different kinds of transportation services in your community to which you can refer clients, not only so they can make it to an appointment with you, but also so that they can make it to an appointment with the food bank or to the employment office or to the consumer network to meet with peers. And finally, having partners, this may seem like overkill, but having established partnerships with community utility groups, people that you can call that work for power, water, and gas, invaluable connections to be able to connect clients to and tell them about those social determinants that are very often overlooked, right? So you might be thinking, we're kind of already doing a lot of this. Like, this is all a lot of great information. Um, and, I have my public health goggles on, but are we kind of already trying to do this? And some of you might be, especially, in the chat, some of you said, oh, we're already trying to integrate this, or, oh, we're already using our social determinant intake data and we're turning it back over into how we adjust for and enact treatment. But really what we're saying throughout all of this training is that you can't help what you can't measure, and you can't treat the whole person without also looking at, assessing for, and trying to address the environment in which they live. Data gathering is important because you can't address what you don't know about. Systematic screening and follow-up is vital to ensure that people aren't falling through the cracks. If people are experiencing challenges, you can connect them with some sort of service to help address their needs, even if it's something that you yourself can't address. And even if your clinic doesn't have these services, you can refer people out to agencies that do have these services. And even if your clinic is thinking, that's a lot of work, we're not going to be integrating screening and measurement-based care and referral systems and partnerships into our work, just inviting people, especially leadership, to think about these domains can be super helpful in getting this kind of measurement off the ground. So just some key takeaways before we wrap up. 3 big things. Providers can and should play a crucial role in addressing the social determinants of mental health, even in your small sphere of influence in your community, in your clinic, in your agency. You have a role to play in treating the whole person through a public health perspective. Screening and systematic measurement can help inform understanding and treatment over time. Taking in every time you meet with a client, taking in those screeners, entering in that data, tracking what they say, what they are self-reporting over time, can help keep clients from falling through the cracks. And then partnering with and referring folks to available programs and practices really can help you to help your clients. So those are our key takeaways. So just really quick before we wrap up, don't have too much time. I just want to ask if you learned anything today, even if it's just something small, if you could just please share in the chat 1 or 2 concrete ways that you hope to apply some of what we've talked to about today in your practice, that would mean a lot to us. It would help us learn, whether or not trainings like this are helpful. Um, but yeah, if there's anything that we talked about today, even if it's just, approaching practice with a more trauma-informed approach, if that's what you're like, yeah, I should really, brush up on my trauma-informed care and trauma-informed approach. Um, Please share if there's 1 or 2 concrete ways that you're going to apply what you learned in your current work. And you can just type those in the chat. The tool, yeah, the tool like is great. If you had a chance while I was talking to just look over all the questions, it really is very comprehensive in addressing all of those social determinants and just asking the right questions and getting some really good info from clients. Anybody else? Yeah, definitely share the tool. It's right there to download for free. It's open. Trauma informed approach. Mhm. Definitely. So Shreya, would you mind resharing the PDF of the HRSN tool for folks so they can download? Excellent. Thank you so much. All right, everybody. If you have any questions, we're right at time. If you have any questions, whether it's about the tool, trauma-informed care, structural competency, measurement-based care, whatever, any of the long-winded things I rattled on about today, that's my email, the one on the top, the Emory one, and then the Southeast MHTTC is our center email. If you have any questions, please just shoot them our way. In the meantime, I'm going to go ahead and ask Sushraya to drop our SAMHSA required survey in the chat. If you'll just follow this link and take just a really brief second to fill out the SAMHSA required survey, filling this out really helps us to report back to our funder and to learn more about how to give trainings like this one, improve trainings like this one, and continue to provide what I hope is really helpful information for you guys as providers and as directors, administrators, etc. So, all right, thanks everyone. Okay, well that